What we're talking about today, everything independent medical groups need to know before 2025. So a ton of really good information today, and I will go ahead and introduce my co-speaker with me today as well, Shawntea Gordon. I'm extremely excited to be co-presenting this information with her. She is a colleague of mine. We've worked together on a variety of collaborative projects over the past several years, and first time collaborating on a presentation. So I'm really excited for our clients and subscribers to get to hear from Taya. She's a wealth of knowledge, and I'm going to pump her up a little bit. She has a couple best-selling MGMA books, specifically focusing on revenue cycles. She's a national speaker and educator. She is the creator of a national RCM certificate at PMI and MGMA. She's an adjunct professor at Howard University, a Creighton Executive Healthcare MBA graduate, a Creighton University Medical Center Bergen Mercy Community Board member, and also an MGMA Government Affairs Council member. And so given her involvement in a lot of that, she has some really good updates for you today on what's coming down the pipeline from a Medicare perspective and all of the changes that are in that final rule, but also maybe what's lingering in Congress, even that's not even included on these slides, but in the hopper. So she's going to speak on that. And many of you know me. I'm Lauren Duren. I'm a healthcare director here at Lutz. I do a lot of these presentations for our clients and subscribers. I've been with the firm for almost 10 years now, specializing in healthcare consulting, and our contact information is up here on the screen. If you have any questions, please don't hesitate to contact us after this, but we will also be monitoring the chat throughout the presentation. So please throw your questions in there as you have them. We'll try to address them throughout, or we may address them at the end, depending on the nature of the question. So utilize that feature throughout the presentation. Now we'll jump into the agenda here. Today's overview, we're really going to hit on several things. Taya is going to go through the key 2025 Medicare changes and revenue cycle optimization strategies, and also implementing CMS Final Rule requirements, things you definitely need to know pre-2025. And then I'm going to jump in and talk through some best practices for financial success going into the new year and some key hot topics as we wrap up 2024 going into 2025. So Taya, I will let you take it away.
Thank you so much. And what a kind intro. I feel like you should intro me everywhere I go. That was so kind. Thank you. Yes, I have some very exciting stuff to talk to you about today, and not only what was issued out in the final rule for 2025, but also some updated information just based on what's happening in Congress right now on the Hill. So to jump right in and get you started, when the final rule came out, it came out sort of the second week of November as a public notice and was officially published at the Federal Register last week. It contained a lot of information. We're going to go over the high level stuff, but I want to start with the conversion factor because I think the conversion factor is something that most of us focus in on. We know that that conversion factor impacts our entire reimbursement schedule. And so whenever we see that conversion factor go down, it can be pretty frustrating, I think, just across the board. One thing we have seen the last 5 years in a row is that that conversion factor has been decreasing pretty much since COVID. And we've had a lot of sort of augmented, I would say, legislation to help offset that the last few years. There wasn't anything in the final rule that would offset this conversion factor decreasing. Now, while I say that, I do want to give a little bit of a brief explanation because I think CMS gets a lot of sort of aggression about the conversion factor decreasing. But the conversion factor and the RVUs are kind of tied together. So Congress gives CMS a budget every year, and no matter how many RVUs are, performed during that year, no matter how many services you perform during that year, there's only a certain number of dollars that Medicare can pay out. So when we have services added, when we have new CPT codes, when we have new RVUs that are kind of injected into that total pool, we see the conversion factor go down. If we see RVUs deleted, lots of deleted codes or services removed, then we see the conversion factor go up. So it's just that mixed bag. They sort of teeter-totter like this. When RVUs go up, conversion factor goes down, vice versa. So that's why we've continued to see a decrease in the conversion factor. It's not because of an undervaluing of the services. It just has to do with the fact that their budget is their budget. A couple of frustrating things that are expiring this year that I want to get out of the way before I talk about stuff that's hopeful. There was no temporary statutory payment increase in this final rule. So the last few years, though the conversion factor has gone down, we've seen statutory rules that help override that by giving us a little bump, maybe 2.5% or 2.8%. We did not see one of those in this final rule. In addition, we had a temporary work RVU floor of 1.0, and we've had that since I think 2020. So any services where your work RVU is less than 1, it would be rounded up to 1 for the purposes of reimbursement. That's been a huge benefit to us the last few years. That is also set to expire at the end of this year without any further legislation. So I know I'm giving you a whole bunch of bad news, but I also want to give you some positive news or some things to look forward to. Right now, there is drafted legislation that is on the floor in Congress, and included in that is adding 2.5% back to the Medicare physician fee schedule. That would help avert some of the cut that we see, right, from losing that 2.83% bump we had last year. It would also extend the work RVU floor through all of next year. It would extend the APM incentive payments, and it would also extend current telehealth flexibilities through 2026. There's a bunch of other provisions in there. We don't know for sure that that is going to go through. So what I'm going to talk to you about today is going to be what was in the final rule. That is what we have that has been signed off by everybody and published to the Federal Register. But keep an eye on the news because there are some positive things potentially changing in Congress literally right now. So make sure you take a look at that. In terms of the final rule, because that's what we're talking about right now, there is a significant impact based on that conversion factor. The total reduction is 2.83%. So if that new legislation goes through, it'll help mitigate some of that. In addition, we had a temporary increase last year and that work RVU floor, and both of those are going away. Now, every year, what CMS does when they put together this final rule, they estimate based on all the changes we're making in this final rule, how do we think that our changes are going to impact each specialty? This doesn't take into account the work RVU floor going away. It doesn't take into account the temporary increase going away. What it's taking into account is services that were added, services that were removed, relative value units that were changed, right? That were weighted differently. So it's only taking into account what specifically CMS has changed in this final rule. When we look at what they've traditionally done with the final rules, it hasn't been great, right? We see that the cost of inflation has been going up and up and up, while the physician updates and total payments for physicians have barely increased at all. One thing that is great to know is that most of the associations are helping to push for significant change. So you have like AMA, MGMA, AHIMA, AAPC, all of those entities and associations recognize that physician payment is in desperate need of an update. That said, we do estimate some significant impacts. So CMS, in their final rule, which you are absolutely welcome to read, it's about 3,000 pages. If you don't want to read it, that's kind of why we distill this down for you. But they estimate that based on the changes they made, there are a lot of practices and specialties that are going to see a decrease. And then there's a handful that might see an increase. So for example, if you do interventional radiology, you may see a decrease of between 1% and 2%, again, based solely off of the changes that Medicare made in this rule. So that is in addition to the work RVU floor going away and the bump, that little temporary bump that we had, that I think it was 2.9 going away. So keep an eye on the news to see if those offset, because then these decreases could potentially seem bigger to you. Your estimated total impact might be closer to 4 to 5% decrease, whereas those estimated increases of 1 to 2% might actually be more closer to net neutral once that work RVU floor goes away. Now, if you don't see your specialty listed on here, then you are projected to have a net neutral impact from the conversion factor change and all other changes that they made in this CMS final rule. But again, Keep in mind that work RVU floor going away and that little temporary bump that we had going away. There is a little bit of a difference if you were billing non-facility versus facility. This is just kind of a snapshot out of there. I know nobody really wants to read the 3,000 pages but me. But if you go out to the Federal Register and you pull down that final rule and you want to know what the difference is non-facility by facility, just search for Table 111. You can just Control F or Command F if you're on a Mac and type in Table 111, and it will pull up all of the specialties for you. So, for example, if you see general surgery is projected to be a net neutral impact, it's actually not across both facility types. If you're billing at the facility level, it's net neutral. But if you're billing at the non-facility level, they're actually projecting a slight decrease. This is more noticeable with things like hand surgery, where hand surgery is looking at a -1, right? They're looking at a 1% decrease, but not at the non-facility level at all, right? At non-facility level, that impact is looking net neutral. In the facility, it's looking like a 3% decrease, which is fairly significant. So it is worth going out, looking at Table 111. We were going to put it into this slide deck, but it would have extended it by 10 slides or so of just us flipping through these changes. So definitely go out, look at Table 111, look at your potential combined impact from CMS. All right, let's talk about some of the interesting and fun stuff that they're doing. So CMS has been working on adding, if you've noticed the last few years, tons of things around preventive management, around self-management, around, just SDOH, barriers to care, and reimbursing for things like that. So one thing that they're introducing now is caregiver training services, or CTS, and there'll be a ton of fact sheets and MLNs coming out from CMS after the new year. So keep an eye on the CMS newsroom if this is something you're interested in. What I like about the introduction of caregiver training services is that it provides a reimbursement method for something most providers are doing anyway. So if we look at this base code here, the 97550, that's caregiver training and strategies and techniques to help patients' functional performance in the home or in the community with ADLs, with communication, with swallowing, with problem solving. So let me give you a for example. For example, my grandfather had dementia when he was alive. There were a ton of us that had to take care of him. He was also a wanderer. He would just take off, right? So we had a lot of things we had to do. We needed to know what his triggers were, things like that. His physician spent a lot of time with us, anybody who was one of his caregivers, talking to us about the best ways to approach him, how to help him with things, how to help him with swallowing, because he also had an issue swallowing, getting himself dressed, things like that. All of that training was done by the provider, and they weren't billing for that service, that they were educating us. But as caregivers, we have physicians giving and providers giving us a lot of training and education, right? And sometimes that looks a little bit different. Sometimes it looks like wound care, things like that. In this instance, for these codes, the patient does not need to be present, right? So this is an initial service of 30 minutes at that 97550, and then there's an add-on code for additional 15 minutes. They are going to outline a lot more details around caregiver training services, but what they recognized was this is a service that's currently being rendered that isn't necessarily being reimbursed in a proper way. So as we see the conversion factor continue to decrease, we see the work RVUs returning to what they were, we have to make sure that everything we're doing that is reimbursable, that we are billing for that service. So make sure if you're providing caregiver training services of any kind, that you're taking a look at these new codes and whether or not they're applicable to what you're doing. CTS services in themselves, they've already approved for telehealth services, which is fantastic. They've been added provisionally for telehealth services. So if you're ever wondering what's on the telehealth services list, when do they expire? Because we know not everything was added permanently. CMS has their telehealth services list. If you go to cms.gov and type that in the search bar, you can pull up their telehealth services list. I highly recommend just bookmarking that, because what is on there provisionally, what's on there permanent, it does change pretty frequently. So just bookmark that, keep that tab available. But the caregiver training services were added provisionally for the entire calendar year of 2025, mainly because CMS kind of wants to see how often is this happening and how often is it happening via telehealth. Is it appropriate for telehealth? Is there any concern to patient care, or is this genuinely a better platform to provide that service? So right now they're kind of in information gathering mode. So we have those caregiver training services codes, and we also have some HCPCS codes, some associated HCPCS codes that were added. And those mainly have to do with like behavioral caregiver training services. Again, you're going to see MLNs from the Medicare Learning Network come out. So just keep an eye if this is something that you think that you're doing, that you think your providers may be able to bill for, then it's definitely something that you want to make sure you have in your arsenal, and that you're looking at the details of those billing requirements when they fully come out from CMS. There were also some changes to office outpatient evaluation and management visits, or what CMS likes to refer to as OO-E&M services. So CMS finalized a proposal to allow payment for a complexity add-on code, the G2211, when the base code is reported by the same provider on the same day as a preventive service. So there's been a lot of questions around G2211. When is it appropriate to bill? When is it not appropriate to bill? We as a community, any of us who are doing legislation and reporting back other types of information to Congress or to CMS, we have made it very clear that there's a lot of confusion still around G2211. So you should see some updated information coming out, updated education on G2211 in the new year. But this is a nice change that you can do G2211 on the same day as a preventive services visit if it's the same provider and the same day. And I see that we have a question in here. Does it have to be a provider, or can it be a nurse for caregiver training services? I believe that it also encompasses other clinical staff under general supervision. However, I would say wait until the MLN comes out, wait to see if it's specifically and explicitly listed. If it isn't, in the meantime, you can reach out to CMS for clarification. There's a ton of contact information. And it's actually, I really appreciate the question because it gives me an opportunity to tell you guys one more thing. I know nobody's going to go out and read that final rule. That's fine. But you should absolutely download it, because in the first 5 pages, it's the direct contact information for the people at CMS that you would need to speak to on a variety of issues. So for example, if you said, I have a very specific question for caregiver training services, it will say, okay, call Michael and here's his phone number. Here's his direct line. CMS is incredibly responsive to physician practices. So saving those first 5 pages of the rule that have that contact information is very helpful. So if you don't see it in an MLN and it's not specifically answering your question, the person you would need to talk to directly at CMS is going to be listed right in there for you. But great question. All right. So let's talk a little bit about telehealth changes. There are a lot of changes happening to telehealth. Hopefully, all of you are already partially aware of this, but most of the temporary flexibilities that we had during COVID, they've had a number of extensions, right? But most of them are set to expire at the end of this year. Now, we've been working on some legislation to try to extend that even further, but as it stands right now, nothing has been passed that will allow you to continue to do telehealth services for everything. Most telehealth services that are being retained long term have to do with mental and behavioral health. So this is why I highly recommend go out to CMS, pull down that telehealth services list and bookmark that page, because these things change regularly. And if they pass new legislation, then that new legislation is going to extend these dates beyond where they're at right now. So right now, beginning in January 1, an interactive telecommunication systems, so basically phone, or if you're talking through the web, right? Maybe you're on a Zoom or something like that. It can include any two-way real-time audio-only communication technology if the Medicare patient is in their home and the provider is capable of using a video service, but the patient isn't or does not want to. So let me explain what this means. Right now, and really throughout COVID, we had the ability to have audio-only telehealth visits, which were fantastic, especially for our rural patients. I don't know about you, but I have a lot of family that are, in rural areas, or they're farmers or what have you, and they do not want to come into the office, right? Even just elderly patients. I have a lot of elderly family that is like, if I can just do it over my computer, why would I go into there? However, this is also the same population that doesn't necessarily always have access to broadband internet. So sometimes that call has to be audio only. You can do audio only services for some telehealth services if you, as the provider office, have the full capability to do video, but the patient either doesn't have the capability or they simply do not want to. So you can't initiate and say, okay, let's just do an audio call with the patient. That would not qualify for a telehealth service. It has to be the patient saying they don't want to be on video or they don't have the capability. So just keep that part in mind. The other thing I really want to clarify here, they're always going to say real time when they want you to have an actual back and forth conversation. And the reason they're making that distinction is because there's a prevalence now of codes that are asynchronous. So think like RTM services, remote therapeutic monitoring. Some of that is through asynchronous data, meaning it's not happening at the same exact time. So think of that more like text messages, where I message you and you can answer back whenever you want. That's our asynchronous methods. So if it says real time, it means you're having an actual conversation in real time. So let's talk about some other changes here. So through 2025, CMS is going to allow providers to use their currently enrolled practice location instead of their home address. I cannot tell you guys how big of a struggle this one was to get approved. So if you don't follow closely with legislation, just a quick background, what CMS wanted to do was for any provider that's providing telehealth services, let's say from their home, right? Maybe 2 days a week, they just do all telehealth and they're working from home. CMS wanted them to register that location as their distant site location. And what effectively that would have done is made the provider's home address on public record. And that's dangerous for most of our providers for a variety of reasons. And I think even more so in the light of what happened recently in the news with United Healthcare, right? It's not always safe for executives, for providers, and especially not to have their home address made public information. So there was a heavy pushback from providers, but CMS was also pushing back. This is something they really wanted to see go forward. The reason I'm honing in on this is because we did get it pushed through that they will still allow providers to use their practice location instead of their home address, but we only have it pushed through right now through 2025. So if this is something you feel is important or something you feel may impact your providers, we highly recommend you send your comments in, whether it's to local legislators or to CMS, because this is a piece of legislation we barely got through. We tried to express the urgency, the dangerousness, but it did not go through as quickly as we hoped it would. So I'm a little concerned that's going to come back up in 2026. Notably, some other positive changes. There's a handful of services where they're changing the definition of direct supervision to include to permanently allow for a supervising physician to provide supervision via that real-time audiovisual. So basically, if there's a service and let's say your PA needs to have direct supervision in order to provide that service, that if they can get their provider, their supervising physician on FaceTime or a Zoom call or Teams, that satisfies the direct supervision requirement. Again, this is only for certain services, so you would have to look under that telehealth services list. Again, why it's so important to make sure you bookmark that and have it. But it's really important to note that that's going to help with access to care, right? So if you're struggling right now with some direct supervision services, take a look and see if those are one that's on the subset for telehealth services list. Something else that's beneficial for teaching physicians, if you are a teaching physician or in a teaching setting, they are going to allow teaching physicians to have a virtual presence for the purposes of billing services for residents who are in teaching settings, but only in a clinical instance if the service was furnished virtually. So this is going to be through 2025. If they weren't going to make this permanent, and we don't know, but if they didn't, then basically what they'd be saying is if you are doing a virtual visit as a physician who is in a teaching setting and you still have a teaching physician with you, then both of you would need to be in the same place for that virtual visit to take place. As of the legislation right now and through 2025, that's not the case. So if you're doing a virtual visit and a teaching physician needs to be there to supervise you for a portion, they can just hop into the Zoom room with you for right now and be there for that portion and then hop back off. So keep an eye on this legislation if you're in a teaching setting. If it does not get permanently added next year, in 2026, I should say, if it doesn't get permanently added then, that it might just shake up a little bit of the dynamic in that clinical workflow. All right. The Consolidated Appropriations Act of 2023 is what extended most telehealth services through the end of this year. There are often Consolidated Appropriations Acts, but I think it's becoming a little bit more well known based on just how big it was in 2023 and how many changes were made in 2023. If we don't have congressional action to extend all of those flexibilities that were made, then any telehealth service you're doing, if it's not for behavioral or mental health, there's a risk of the ability to do that via telehealth is going to go back to the way it used to be. So just to clarify, the way that it used to be is that the originating site for the physician and for the patient could not be in the patient's home or the provider's home. Basically, you would need to be in a clinic as the provider, and the patient would need to be in a clinic also, kind of defeating the whole purpose of telehealth. But you have to remember that when that was put into place, telehealth wasn't really a thing. So it was more designed for, let's say, a rural patient goes in to see their primary care doctor and they need to contact over the internet a specialist in another state, right? And so it'd be the provider sitting next to the patient on video call with another provider. That was how it was originally put into place. It's obviously not how things work today or how they make sense to work today. CMS absolutely recognizes that, but this is something that needs congressional change. In a lot of ways, CMS has their hands tied by statute. I will say that the legislation that is on the floor right now would temporarily extend that, give them more time to make that rule permanent. So again, keep an eye on the news. You'll probably hear me say that a lot, but there's a lot of potential positive things coming up. Um, Medicare beneficiaries are going to be, will need to be located in a medical facility in a rural area to receive most Medicare telehealth services, with the exception of behavioral health. Again, unless we get that legislation extended. So if you're doing telehealth right now of any kind in any setting, and it's not limited to mental and behavioral health, pull up the telehealth services list to see when those services expire from being allowed to be performed by telehealth. CMS also finalized that interactive service can be audio only, like we talked about. But again, it has to initiate with the patient. You have to be capable of doing the video call, and it has to be the patient who says, no, thank you. Now, if you do bill an audio only visit, let's say you meet all the requirements, you're capable of doing a video call and the patient's like, I can't be on video today. I look terrible. I don't want to hop on the phone today. Let's just talk. I don't want to be on video, right? If you meet those requirements, then you can bill, but you have to attach a modifier. So if you're an FQHC or a rural health center, you're going to attach the FQ modifier. If you're any other facility type, you would attach modifier 93. Those indicate that it was an audio only visit. This is really important for a couple reasons, right? One, if your charts are audited and it was audio only and you didn't put it on there, you're going to get your hand slapped, right? But the other reason it's really important is because we've all, and when I say we, again, I'm talking about the associations, we've all been pushing with Medicare that this is more important than they realize, that for a lot of patients and access to care, they are more comfortable hopping on the phone with their provider than they are hopping on a video chat with their provider. So this is also information gathering, right? So when you're actually performing these services and a patient says, I just want to do it over the phone, please attach that modifier, get that information to CMS so they understand how often that's being requested by patients, because that is what helps us make things like this permanent. So let's talk about virtual check-ins. So CMS is going to delete one of the virtual check-in codes, G2012, because instead they're adopting a CPT code for it, 98016. The rules for the code are going to stay the same as they were before, and it's basically 5 to 10 minutes of a medical discussion with a patient by a QHP, and it does need to be initiated by an established patient. So this wouldn't be for any new patients. And the goal of this, using the virtual check-in, is to decide whether or not the patient needs to be seen in person. So let's say a patient calls in, they're an established patient, and they're like, this is what's going on with me. I'm not feeling super well. I'm running a fever, and this is happening. And the physician hops on and says, you know what, you don't need to be seen, but I do want you to do X, Y, and Z. That call takes 5 to 10 minutes. You could bill this 98016 for that service. If it ends up being that the patient needs to come in and be seen, And then the rules of what you would bill and when change a little bit. So again, this is one of those areas where you want to see a more detailed MLN that will come out from CMS after the first of the year. So just keep an eye out for that to come out shortly after the first of the year. Something else that came up for CMS that I'm kind of excited about just because I like to see whenever new codes are added that I think are going to help from a reimbursement perspective. So advanced primary care management. The last probably 7 or 8 years, CMS has really been focused on care management reimbursement codes because they're recognizing that the more touches that we have with patients, the more frequently we're talking about prevention and self-management, the healthier our patients are, the less exacerbations we have, the less cost to the industry overall. So, one of their areas of focus is in primary care management, making sure patients see their primary care doctors. But they also recognize that sometimes primary care providers are dealing with complex patients that maybe don't yet have their chronic conditions being managed by a specialist, or maybe there's not even a specialist in the area that can manage it and the physician, the primary care physician has to. So advanced primary care management services, they include all the same elements as you would see in like chronic care management or transitional care management code, right? Where we're documenting, we're creating a care plan, we're discussing that treatment plan with the patient. We're helping them address any barriers that they would have toward, achieving that treatment plan correctly. So these codes that they've created here are specifically for primary care providers. So let's say you have a patient that has one chronic condition. This would be similar to the 99490 code. There was a bit of a discussion about the duplication, right? Is it necessary to have 99490 and to have this separate G code for APCM? Again, this is one of those areas where CMS is sort of in information gathering, right? There's a lot of specialists that bill 99490, but how often is the primary care physician the one who is managing that care? So this will help them identify that a little bit. The G0557 code is for patients who have multiple, two or more chronic conditions, right? So again, you see the chronic care management codes. You also see complex chronic care management codes, and you see that reimbursement rate get a significant bump. The last code is for qualified Medicare beneficiaries or QMBs, right? So these are patients who are usually dual eligible, but it also helps people if they have Medicare and they have a low income. And so that way it'll help support them with their premiums, their deductibles, et cetera. But usually this patient population also has some other element of barrier to care, right? Whether that's access to nutrition or health literacy, or access even just to transportation to get back and forth to the office. So what they're trying to do is identify for each of these services that primary care providers perform, how frequently are they performing these, and is the reimbursement rate accurate? So you'll see that the work RVUs have been mapped to the reference codes that are listed in this table. And again, we do expect to see a more detailed MLN coming out of CMS for this. Another code that I'm excited to see be introduced, because again, this is one of those services that I see performed often that I don't know there is a reimbursement methodology for yet. So CMS finalized payment for a G code that can be billed in 20-minute increments when safety planning interventions are personally performed by the billing provider. This is specific for suicide safety planning. So if you have a patient with suicidal ideations, it's that provider sitting down and having a conversation of, okay, let's identify what your triggers are. What do we do when we identify that we have been triggered? How do we avoid places that are triggering to us? Things of that nature, right? Having those conversations and having a safety plan created is really important for patients with suicidal ideations. And now there is a specific reimbursement code for that. In addition, a monthly billing code that has some more specific protocols for post-discharge follow-up. If you have a patient who's discharged for the emergency department for a crisis encounter or something like that, can also be billed. So CMS is going to release a lot more information about safety planning intervention codes because they are also reviewing digital mental health services and releasing some codes in that area. So what they're trying to do is recognize the impact of mental health, the impact of behavioral health, the impact of suicidal ideation, and what that looks like and how it impacts the industry overall, not just in increased ED use and crisis use and things of that nature, but also in making sure that our providers are educated, that they have the resources that they need, and that they're being reimbursed when they're helping manage these services. So CMS is releasing new digital mental health services codes. They're also going to release 3 new HCPCS codes for digital mental health and 6 for diagnosis and treatment of mental illness for providers who may not be able to bill E&M visits. So if you're a provider type that isn't able to bill an E&M visit, these codes are being created for you so that you can be reimbursed for diagnosis and treatment of mental illness. So again, just helping, trying to help expand that access to care so that we can really take care of these patient populations in what's generally considered a very underserved area. I will say, when it comes to opioid treatment programs, CMS is doing a lot of clarifications. They have some opioid treatment programs that exist already, and they are making permanent the flexibility for doing periodic assessments via audio only beginning January 1. So same requirements apply. Right, it has to be on the patient, not your decision. You have to be capable of doing the video call. You need to apply the modifier, but they are making that permanent. So if you have a patient who's in an opioid treatment program and they just want to call you on the phone, that is permanently acceptable through CMS starting on January 1. They are allowing the OTP intake add-on code to also be furnished via two-way audio video if it's being billed in addition to or alongside the initiation of treatment with methadone, if the opioid treatment program determines that evaluation of the patient can be accomplished through that video call. So if you have a patient and you're starting them on a methadone treatment plan in your opioid treatment program, and you hop on a video call, if you feel that it's acceptable to also do their intake that way, then you have an add-on code now to bill and be reimbursed for that. Again, because as we see the conversion factor go down, we want to make sure we're billing for everything that we can do. They've also reevaluated the payment amounts for SDOH risk assessments as part of opioid use treatment intake. They did some assessments to see if they felt that the RVUs were properly evaluated. So there've been some updated payment amounts that you'll see there. And this is probably the most interesting clarification they had. But if you are providing opioid use disorder treatment services, the patient must have an opioid use disorder diagnosis. This is one of those things that sounds like common sense. Before you provide a patient with an OUD service, they need to have an OUD diagnosis. But so frequently, people were billing for OUD services for patients that did not have an OUD diagnosis on their claim, that CMS had to make a separate rulemaking clarification to make sure that everybody knows that this is a requirement. So please pass it on to your billing staff. My estimation is that it wasn't patients didn't have the OUD diagnosis, just it wasn't in the proper location on the claim. So make sure you're also putting your diagnosis codes in the proper order on those claims before they go out. So let's talk about some changes for FQHCs and rural health centers. If you are a federally qualified health center or a rural health center, you have some big changes in terms of care management. So to date, you've had G0511 as kind of a catch-all care management code. If you did chronic care management, you build G0511. Transitional care management, G0511. Complex chronic care management, same code. Behavioral health management, same code. To date, for all of those codes that have been created since about 2015, you guys have only used G0511, but in 2025, that is going to change. Now, it will not change until July 1. They've given you a 6-month transition period, but what they want is for all FQHCs and rural health centers to start using the individual CPT and HCPCS codes instead of that catch-all code. So that means you're going to have to bill the 99490 for chronic care management. You're going to have to bill the 99495s for transitional care management. You're going to need to know what those codes are and educate your staff, educate your billing departments, because the billing requirements for all of those vary. Where some are 30 days, 30 straight days, others are the calendar month. So you do need to look at what those billing requirements are. This is a big change for FQHCs and rural health centers that have always been able to use this catch-all code. CMS is going to continue to allow direct supervision to extend the definition of immediate availability to include that real-time audio video discussion. So if you can get a physician or provider on video call, that will count as immediate availability, but temporarily, right? It's provisionally added through the end of 2025. So if you're hoping to see that made permanent, again, I highly recommend reaching out to your legislators or even your specialty associations to let them know that's something that's important to you. And in the interim, keep an eye on that telehealth services list to see if it is made permanent. And then lastly, CMS is going to allow rural health centers and FQHCs to bill and to be paid for Part B preventive vaccines and administration for all services after July 1st. So leading up to July 1st, your focus is making that shift on care management codes. Once you get to July 1st, that's when you can start billing for all of those Part B preventive vaccines and administration. So again, just making sure that you're billing for everything you're eligible to be reimbursed for to really optimize your revenue. In terms of therapy changes, CMS did finalize a regulatory change for therapy services. This is kind of a big change in terms of access to care for therapists. So this would allow for general supervision for physical therapy assistants and occupational therapy assistants by physical therapists or occupational therapists who are in private practice for any applicable therapy service. So basically, you would not need to have the physical therapist right there on site at all times. General supervision is now going to be allowed. That starts to align with the general supervision for institutional providers. And institutions, general supervision is allowed, which is why they're now trying to bring more alignment by making that allowed on the private practice side. And the goal, obviously, being to extend access to care, to be able to be more flexible to meet the needs of beneficiaries, and just really to safeguard access to medically necessary services. So if you have a PTA or an OTA providing those services, that they don't need to have the physical therapist there on site in order to provide their services. They've also, in kind, amended the regulations to provide an exception to the signature requirement for established treatment plans. So if there is a written order or a referral already on file and the treatment plan has already been transmitted, then there is an exception to that signature requirement. So trying to ease some of the administrative burden while increasing a little bit access to care. So I want to talk to you a little bit about payment updates with vaccinations. And this is a little bit of a sticky wicket also because it's one of those things where we're kind of waiting for legislation to change. So we're giving you a partial answer here. So I got a lot of questions a few weeks ago about reimbursement for COVID vaccines and the reimbursement rate. So in this chart on the left, you can see the reimbursement rates for influenza, pneumococcal, Hep B are a little bit less than for COVID vaccine. That is because there is still a temporary emergency use authorization declaration in place that has been in place since COVID began. Whenever that EUA declaration expires, that reimbursement rate, that elevated rate, will stay in place through the end of that calendar year. So, for example, if the FDA says that EUA expires right now, if that were to happen, then our reimbursement for COVID would be decreased starting January 1. If they don't decide that till February, then for all of 2025, we are going to bill that higher COVID reimbursement rate. So the reimbursement rate is going to decrease the year after the EUA ends. So it's a little bit of a complicated one. So for that reason, we wanted to give you both visuals on that. So on the left, you're seeing what it looks like right now with the EUA declaration in place. Once the EUA declaration fully expires and goes away, COVID is going to be rolled up to be in alignment reimbursement wise with influenza, pneumococcal, and Hep B. So you can see that little bit of a difference here. We'll go from $44.99 to $33.74. And that's just to get the COVID vaccine in alignment with those other preventive service vaccines. And I do want to mention quickly the in-home additional payment because we've seen some providers kind of getting in trouble with this. If you're going into the patient's home to provide vaccine services, there is an add-on code that you get for going into the patient's home, and you bill it one time per home. So if you go into a home and there's 2 patients in there, you bill your influenza vaccine once to each patient and you bill that in-home payment one time. It is one time per house. So do not bill that one per patient, because we have seen some providers get into a little bit of trouble for that. All right, clinical lab fee schedule. The clinical lab fee schedule, as hopefully most of you know, is decreasing. It is set on a trajectory to continue to decrease over time. It was determined last year that the clinical lab fee schedule was way too high, and so they have set basically a schedule to decrease that over time. So for reporting period in January of 2026, that will be the collection period of January through June of 2019. So we're still working with data that is pre-COVID. So if you're looking at clinical labs, or you have a clinical lab and you're wondering about that fee schedule, if you go out to cms.gov and search CLFS, you will see all of the information on how those rates are decreasing and the rate at which they're decreasing. I will tell you, in 2025, the payment amount can't be less than it was in 2024. So no immediate changes, but it is something you need to know is coming up for 26 through 28, because there will be some significant decreases to the clinical lab fee schedule during that time. Other changes for patients that you might want to know about. The monthly premiums for Part B are going up, so is the annual deductible. The admission deductible is increasing significantly, and so are some of the coinsurance amounts for patients that are inpatient or admitted. One thing that I thought was very nice that I like so far, the yearly cap on out-of-pocket prescription drug costs, and what sends patients into that donut hole has been a point of frustration for patients and providers for a very long time, because it impacts adherence to treatment plans. Starting in 2025, the Inflation Reduction Act is going to require all Medicare prescription drug plans to offer patients the option to pay out-of-pocket drug costs in the form of capped monthly payments instead, meaning all patients starting in 2025 will be given the option: do you want to pay a higher monthly amount, or do you want to hit that donut hole sometime randomly throughout the year? So now giving patients the opportunity to take control of their own budget and prepare more accordingly. So I'm very excited about that, because we know that is a problem with patients and with medication adherence when they hit that donut hole and they can't afford, because fixed incomes, to stay on their medications. There's also a significant revision to overpayment definitions and timelines. CMS adopted a revision. So it used to be, when an overpayment was identified, that you immediately had to return that money to CMS within 60 days. And what was identified, or that notification that you'd been identified, could be as much as you have an end of month report that auto generates and identifies overpayments. Even if you weren't looking at that, you only had 60 days from the generation of that report to return any overpayments to CMS. So CMS has decided to do two things. One, they changed their definition. Now it has to be that a person identified that overpayment, meaning a human being had eyes on that report, which is significant change. In addition, they're changing the clock from 60 days to return it to 180 days. That way you have time to do a good faith investigation and determine whether or not that money needs to go back to a patient or to CMS, right? So the deadline for reporting and returning that is going to remain 180 days after which the initial identified overpayment was made, or the date the investigation is concluded. So if you do an investigation and you're like, okay, yes, this money does need to be returned, you need to return the money once you identify that, right? Then don't wait 6 more months to send them their money. But it is nice. It's a little bit of an extension, and it provides a little bit of relief to provider offices and billing departments that can't always hop onto those overpayments and get them addressed in a 2-month time frame. A few quick other changes. There's some expanded coverage of Hep B vaccinations, so that no longer requires a physician order, and they've removed coverage of barium enema as a method of screening, while they expanded some coverage for CT screening. I've also included in here for you a ton of links and education. Please use them, click on them, save those links. They will provide you with some excellent information going forward. And if there aren't any questions, I will turn it over to Lauren to talk about all of the financial impacts and fun things happening.
Thanks, Taya. That was an excellent overview. And while I'll speak a little bit more on that, I had a couple questions for you that you can maybe speak on. But while I do that, we do have a polling question for the folks on the line that are trying to get continuing education credits. Please answer the very simple question that's going to pull up here. And then also please email Reagan. Her email is listed here as well to get a certificate for your education requirements. Taya, I know you had a ton of really good information on several new codes being added, and depending on the specialty and the different impacts with the work RVUs and the conversion factor, I mean, it really would behoove the people on the call here to take some time after this to go look at the specific impacts to their practice, educate their teams, brace their providers on potential changes, especially depending on their payer mix and if Medicare is a significant portion of their payer mix. Any just quick tips or tricks for those on the call in terms of things to prepare, making sure they're updating their fee schedules in their systems, things like that, that may be low-hanging fruit for them to set up for success?
Absolutely. And so there's a couple things you can do. So CMS will release their updated fee schedule on their website. So will your MACs. So you can go out to your Medicare administrative contractors and download them. What your physician owners and things are going to want to know, your boards and your other stakeholders, is what is our specific impact to us going to look like? So what I recommend is doing two things. Look at the payer mix that Medicare and Medicare Advantage plans make up for your organization. Let's say it's 30%. Then look at your top 20 to 30 codes that you're billing on a regular basis. For those codes, look at what the reimbursement impact is going to be for you when that conversion factor decreases, and then apply that to 30% of your revenue, because that's the payer mix you've established, and you can start to estimate what that impact is going to look like. This is not a direct impact. This is not a deep pro forma or forecasting that's going to tell you exactly to the penny, but it'll start to give you an indication of how much do you need to evaluate. While you're doing that, take a look at all the new services that have been added and see if that offsets any of that impact whatsoever, right? So if you're seeing a significant decrease in one area, are you also providing a lot of caregiver training services that aren't being billed today that could help offset some of that decrease? So those are a couple things I would absolutely look for before the beginning of the year. Always make sure to update your fee schedules. Remember that CMS is going to reimburse you the lesser of what you billed or what you were eligible to receive. So we always want to make sure that our charges are up to date and that we have that updated fee schedule in our system. So those would be the top things I would recommend. The last thing I will say is please make sure that your front is reminding your patients to update their insurance information, even Medicare patients. Now, while this wasn't something we always had to remind in the past because of the Change Healthcare hack, a lot of Medicare patients got new insurance cards and new insurance IDs. So they should ask every patient every time, scan the front and the back of the card for the billing department, make sure you're getting that information, and that will also help you at the front of the year.
Awesome. Thank you so much, Taya. That was excellent. And those resources that you included, the slides will be sent out to those who are listening. So the resources that Taya included, she mentions to go to the Federal Register, download those, things like that. Please take the time to do that so those references are available for you going forward. So we'll dive in. I know we don't have a ton of time, but I am going to zip through some accounting updates and hot topics that are going to be important reminders, some potential updates, depending on how much folks on the call here are watching all of our e-blasts. I'm going to give a quick overview of some of those as well. So from a compliance filing perspective, just a couple reminders. For payroll perspective, I know a lot of the folks on the call here may outsource their payroll, but many of you are also still processing payroll in-house. So January 31st does fall on a Friday this year, so that is the due date for all W-2 related filings. A few things just as general reminders to do prior to January, or depending on when your deadlines, if you use a third party, oftentimes you'll have a deadline to make sure all your information is updated, but making sure any employee names, address changes, anything like that, make sure all of that's updated before year end, before those forms are processed. Also, with remote workforce, make sure whenever we have workers that are performing services remotely, we're notifying our payroll providers or our income tax providers and advisors on that, because there may be different state income tax withholding or even state tax filing requirements. This is often missed by many. So please take a look at that. If you do have any remote workers, make sure that that is communicated to the appropriate advisors. And then back up to the first point there, many of you are likely already reporting fringe benefits. But just keep in mind, some of these fringe benefits that are reportable as compensation, especially as we are getting creative from a recruiting and a retention perspective, starting to offer sign-on bonuses, providing stipends for specific expenses, or getting more robust with the benefit packages that we're offering. Make sure you're having a conversation with your advisor, your payroll advisor, your tax advisor on what is reportable as compensation. Are we reporting this correctly? There's a lot that comes up throughout the year that we may not necessarily think is reportable as compensation, or, oh, that actually does need to be reported on our employees' W-2. So if you're unsure, definitely reach out, ask the question. These are things that definitely need to be calculated and reported well before the W-2s are filed, and many of them need to be done before the end of the year. So again, as we continue to get creative with those fringe benefits, make sure you're reaching out if you're unsure what's reportable there. Then switching gears to Forms 1099. These are also due January 31st. It is best practice to be gathering those Forms W-9 from any contractor that you're paying throughout the year, even before you pay them, to aid in these filings. If you're unsure of the requirements of this, we do have additional information. Lutz has a really good blog on 1099s we can send out as well if you have additional questions on this. But be aware of the filing requirements for this, and also the documentation required to get these filings done. This, the IRS e-filing regulation was in effect last year, but just a quick reminder, there is an electronic filing mandate for entities that have 10 or more information returns, and that really is the Forms W-2 and the Forms 1099 combined. So if you're issuing, let's say, 5 W-2s and you have 6 1099s, then you are mandated to be e-filing. Hopefully many of you are already e-filing, but I know there are a few of you on the call here that may not have fallen into that camp last year. So definitely be aware of that if that impacts you as well. Depending on the number of Forms 1099 you're issuing and then the number of Forms W-2, you need to combine those to determine if you have that e-filing requirement. Again, the slides are going to be sent out, so you guys will have all this information. Both Taya and I put a ton of really critical information on the slides for your takeaway. So I'm putting the 2025 federal payroll updates listed here. You can see that compared to 2024, I'm not going to go through these in detail, but I will just mention in terms of the different increases on the different wage bases. Obviously, there's a lot of planning that goes into a lot of your physician shareholders at year end of maybe bonusing them to make sure they're at that max compensation plan limit so they can max their retirement. Keeping in mind the increases to HSA, all of these things as you're updating either your internal payroll or notifying your external payroll, these limits do need to be communicated if anything needs to change for 2025. Or keep in mind, as you're doing any year-end bonuses, these limits, because I know there's a lot of planning that goes into that. So this will be sent out for those who need to reference these limits. Other compensation considerations, I'm just going to zip through these in the interest of time, but it's definitely a good time as you're in the thought process of year end and going through all of your year end processes, looking through your employment contract and reviewing for expiring contracts or contracts that are up for renewal. Are there any enhancement opportunities for retention? From that standpoint, I mentioned the fringe benefits on the earlier slide there. From a recruiting perspective, we are seeing compensation models get very dynamic at this point, especially to be competitive with recruiting those newer physicians. A lot of the models are not just base salary and not just containing a productivity metric. I have a whole nother physician comp presentation on that, but it's a really good opportunity as you are going through the year-end reporting process to give thought to what do we need to consider for next year. And then again, with those fringe benefits. A lot of folks are now offering sign-on bonuses. There is the student loan repayment programs, flex scheduling, and other enhanced benefit packages. So I'm listing this on here to put a bug in your ear, to be giving thought to this well before you get a week out from having to send a proposal to somebody to recruit them to your practice. So keep some of these things in mind. Reach out if you want to talk through in more detail and how this relates to your practice or any physician compensation considerations or other providers not specific to physicians. I'm going to zip through these other business topics for 2025 in the interest of time. There is a lot of confusion on the business meals and entertainment because there's been a lot of changes over the last few years. So there's this visual on here that just explains the different types of business meals and entertainment expenses and how they have been deductible pre-2017 and post-2018. And then you can see there is a change with the employee meals provided by the employer, which will be deductible 50% through the end of 2025. So there's a lot of changes here because I think a lot of people are still thinking just meals and entertainment generally are 50% deductible. Well, since 2018, meals are 50% deductible. Entertainment is no longer deductible at all. And then in 2021 and 2022, post-COVID, there was a temporary 100% deduction on meals because of post-COVID and trying to revitalize the restaurant industry. But since 2023 and beyond, 50% deduction for meals, 0% for entertainment, and depending on the type of meal, may or may not be deductible. So reach out to your tax advisor. But I wanted to make sure the folks on this call were aware. We get questions on this all the time, and it's not necessarily denoted or tracked very well in the general ledger. So depending on how that is currently tracked, you may want to give thought to that and tracking things a little bit differently going into 2025 to make your year-end reporting a little easier. There's some depreciation changes that are also coming down the pipe that may or may not have been significant in the past because we've always, essentially since pre-2018, have been able to expense 100% of assets placed into service for the most part. Well, that's starting to phase out. It started to phase out last year in 2023, but that phase out is going to continue. And so main takeaway here is don't assume that assets placed in service are going to be 100% deductible. There is potential tax planning consideration. So please reach out if you're doing significant asset purchases and if you need to determine how that's going to impact you from a tax standpoint. I will just quickly go over the Corporate Transparency Act. Currently, there is no longer a January 1st, 2025 filing deadline. There is currently a nationwide injunction due to the U.S. District Court in Texas that essentially stated this is unconstitutional. And so currently this is temporarily halted, but keep in mind that enforcement could resume if this ruling is overturned on appeal. So this may or may not apply, but right now there is no longer a January 1st filing deadline for this. This just kind of goes through the details of what needs to be reported. There is an exception if you're a large operating company. And then do keep in mind, this is not just at the parent tax entity level. This is any legal entity. So if you have several disregarded single member LLCs that roll up into a parent company for tax purposes, all of those would be subject to this reporting. And then there's a lot of scams out there related to this reporting, so be alert to that. But like I said, right now, this deadline has been halted, but keep an eye out. Like Taya was saying, watch the news for updates on the Medicare changes. Make sure you're watching, and we will also be sending an e-blast out if anything changes on this, but need to be aware of your Corporate Transparency Act requirements as well. And then lastly, I will just quickly touch on the Visa and MasterCard class action settlement. This was included in our e-blast that went out in our quarterly newsletter on Monday. So hopefully anybody on this call is subscribed to those. There's a ton of additional detailed information in there, but essentially if you potentially had a ton of patient payments that paid via credit card, via Visa or MasterCard, you may be eligible to receive compensation because of this settlement. And so it would behoove you to look to see if you have significant credit card payments, then this could be a meaningful financial compensation impact to you. So please pay attention. We can send the blog out on this as well. It's also in our quarterly newsletter on Monday that has all the details on this, but we've been seeing some folks have significant reimbursements coming or potential reimbursements coming from this settlement. So it may make sense to explore further depending on how that impacts your practice and what camp you're in there. So definitely, I zipped through that very quickly because I want to be respectful of everybody's time. We will see if there's any questions in the chat here that are related to the accounting items. It looks like we're taking a look here. No questions. Excellent. Feel free to reach out if you have any other questions to either Taya or myself.